So next is hyperparathyroidism. It's V3. 50-year-old lady present with GP with fatigue, constipation, and mild depression. Initial blood test revealed raised calcium, serum calcium, and parathyroid hormone. How would you manage this patient? The raised calcium and raised parathyroid hormone suggest a diagnosis of primary hyperparathyroidism. Fatigue is the most common presenting complaint. I would take a thorough history, looking for other symptoms of hypercalcemia like stones, bones, groans, moans. History of renal disease, transplant, and family history of endocrine disease, especially familial hyperparathyroidism, men 1 and men 2. I would examine the neck. I would request thyroid function test, vitamin D, 24-hour urinary calcium, ultrasound scan, and DEXA scan. What imaging would you request? I would request ultrasound scan and systemic scan. And systemic scan will exploit the differential uptake in hyperfunctioning and normal parathyroid and thyroid tissue. It will localize the parathyroid adenomas. Ultrasound and systemic both show an abnormal left superior parathyroid gland. What operation would you perform? So there are three options here. The operative decision is between the bilateral neck exploration, unilateral neck exploration, or minimally invasive hyperparathyroidectomy, MIP. Minimally invasive parathyroidectomy. With concordant preoperative localization, I would perform a minimal invasive parathyroidectomy. For enlarged parathyroids more than 2 cm, I would consider a unilateral neck exploration. For enlarged parathyroid more than 2 cm, I would consider unilateral neck dissection. Single adenoma is found in 80% of the patients. Intraoperative PTH measurements can be taken to confirm the successful surgery, as the half-life of PTH is 5 minutes, and PTH fall of more than 50% compared to baseline and return to normal range confirm the success. What are the specific anatomical consideration of minimal invasive operative approach? A 2 to 3 cm transfer incision is made centralized on the anterior border of the mastoid. Pain is developed between the lateral to the strap muscle and medial or anterior to the sulcumastile. Key landmark is the carotid artery. Often the recurrent nerve is not encountered in this operation. Give a brief description of parathyroid embryology. So superior parathyroids SO4, they develop from the fourth branchial arch. They are less variable in position, and the inferior parathyroid gland develop from the third branchial arch, and they are more variable in position. What would you do if you could not find the abnormal gland after a bilateral neck exploration? I would ensure I had to look into other infrequent locations. Carotid sheath, retroesophageal. I would consider taking blood samples from each internal jugular vein to compare PTH levels and help lateralize the gland. Other potential sites are the mediastinum are rarely intrathyroidal. However, I would not routinely proceed to operating at these sites without further imaging. What imaging would you request to find the missing gland? There are again three options: CT with IV contrast, MRI, and CT with IV contrast, MRI, T2 weighted image, and parathyroid vein sampling. So what are the post-operative biochemical changes after successful parathyroidectomy? Parathyroid levels may become almost undetectable 4 hours after surgery and then begin return to normal. Plasma calcium decreases in 24 to 48 hours. Post-operative hypercalcemia can occur in the patient who have vitamin D deficiency after a large adenomas are removed, remaining glands are suppressed, and patient has hungry bones. Multiple glands are removed. Elevated serum PTH levels are observed in up 30% of the patient at 1 month post-op, despite normalization of serum calcium levels, probably related to the hungry bones. Thank you.